So now I invite Dr. Sarfaraz Baig. Everybody knows he's a superhero.
You don't know that.
Yes.
He's an extremely good poet.
I know that. I get his poems also, yes. So tailoring bariatric surgery to the patients, whether it is evidence or empiricism.
Thank you very much. We have got absolutely very good chairperson, so it is good to talk in front of such esteemed illuminaries. And thank you for watching coming for this presentation. I'll try to keep it as simple as possible. I thought about how to do this, and yesterday I changed it, trying to cater it to the audience that we will have. So I'll just try to keep it as simple as possible. It is far more exhaustive. But just let's take a look at what the evidence says about a few things. So I will be addressing the three common procedures: the sleeve gastrectomy, the Roux-en-Y gastric bypass, the one anastomosis or mini gastric bypass. These are the three bariatric procedures which are commonly done in India. The rest of them are uncommonly done. Balloons are endoscopic procedures. Today I would like to restrict my talk based on centering around evidence in the three procedures that I have mentioned. So it might be confusing if you start practicing and not knowing whom to give what procedure. It's pretty common when you start the practice. Also, when you read the literature and the arguments in favor and against it, there is a high chance of confusion. So I will just go with some of the data that is accepted by most people. Now, there are many areas at which you would like to exercise your choice of bariatric procedure. I am just listing those which are commonly seen in your practice. For example, you may get a young child at age of 12 years who is very obese. Now, that's a different thing compared to an adult. Two, you might get a 75-year-old who is unable to walk, and the orthopedician said, I'll not do a knee replacement unless you get your weight down, and that person walks into your office. That's a different thing altogether. What procedure are you going to offer? When body mass index goes beyond 30, we call obesity. When it goes beyond 35, it's class 2 obesity. When it goes beyond 40, it is class 3. We don't say morbid obesity these days, call it severe obesity because it will take away the stigma. So, and beyond 50, it's, super obesity. And the more you see, the higher and higher BMI, 60, 70, do you think the procedures are going to work? They're going to fail more often, right? That's what you would think. So what procedure will you apply? Comorbidities like diabetes and GERD deserve special attention because in these diseases, you would like to apply the procedure which causes maximal benefit in these diseases and less worsening. We'll see that as well. There is a patient with more severe obesity with a hernia, and you want to operate the hernia also, or the patient came for the hernia. Then you want to reduce the weight with one surgery. Which one would that be? So that is another very important question. And if there's a previously abdominal laparotomies have been done and these patients are coming, what procedure do you choose? And finally, there are some organ failures like cirrhosis is not very uncommon in a bariatric patient. Even a NASH or an NFLD is not uncommon. What procedure do you choose? CKD I will not touch, that's why I made it in red. Inflammatory bowel disease, another topic I will not touch today. So those are the ones I'm going to touch. I'm just telling you why these are important because this is going to dictate your practice. Now let's touch the adolescent bariatric surgery. Now the reason why it is important to know which procedure to do, because you will have a lot of patients as soon as you have a bariatric center, patients walking in at the age of 12, 13, 14, 15, and then you realize, oh, am I going to do a gastric bypass for this kid and then disallow the nutrients to be absorbed, disallow endoscopy in the future? Also, you would find that the adolescent obesity has increased so much that it is a problem. And these patients are not reducing just like adult patients with medical weight loss. So what do? Do you wait? If you wait for another 5 years till they attain, 18 years of age as we think about a legal age, whereas as Siddharth rightly pointed out, if the patient has attained puberty at 14 and 15, can we still go in? Because by 18, the patient at 14 who has got sleep apnea, diabetes, by 18 may become a diabetic cripple. There may be a lot of more organ dysfunction. More importantly, emotional and social behavior may change of this child. So it's a growing problem. Multimodal treatment should be exhausted before you take them up for surgery. But if you do, and you will find there's a lot of literature coming from centers who do adolescent bariatric surgery, that it is a growing thing and it is accepted to do bariatric surgery in this select group of children who you think will benefit from an early surgery rather than postponing them till about age of 18 or 20. And most authors who have done this prefer sleeve gastrectomy over bypass. Now that is the entire flow I want you to understand. It's a problem. We have to do it sometimes, and then a sleeve gastrectomy because it will not disturb the anatomy of a younger child, and they do better also compared to other cohorts. In elderly people, they have seen bariatric procedures and they found that it is safe to use it except for a cohort of people called sarcopenic obesity. Elderly people are gaining fat, but they are also losing muscle with age. So if you identify sarcopenia, which I will not go in today, which means there is a less muscle mass and a lot more fat, and a sleeve gastrectomy probably will be better because you don't want any more muscle wasting. So again, controversial, one may do any procedure, but again many centers would prefer to identify sarcopenic obesity in an elderly age group and prefer a sleeve gastrectomy. Body mass index. Well, if you have anything between 40 to 50, all procedures will work equivalent in terms of TWL, total weight loss. But when it goes beyond 50, this is our own publication in 2019, where all the centers, including people sitting in the chairs, have contributed, and there were 9,917 patients, 617 patients whose outcomes are looked for 5 years, right? Some had 5 years follow-up, some had 3. But overall what you see is for BMI more than 50, if you look at the definition, which is regain of 25% of lost weight, what do you see? You see that when the BMI is less than 50, the failure rate is lower, the recurrence, weight regain is lower. And as soon as it goes beyond 50, the skyscrapers have gone high. But do you see that the mini gastric bypass is only giving a weight regain which is 0 in that cohort? It is not true, the sample size was small. But what it shows is with the 1 anastomosis gastric bypass in a super obese, your chances of having a weight regain in your patient is still low. So that's what it says. If there is a future pregnancy that has to be planned in a young female who comes to you in their 20s, in their early 30s, then it is known that the bariatric surgery will improve fertility, but it has adverse perinatal outcomes. So the child, the baby, the fetus may have IUGR, intrauterine growth retardation. Some fetal malformations have been reported with a higher incidence to a very small extent. And in these cases, some authors have predicted that, because these ladies come with problems of polycystic ovarian disease, which is a metabolic part of a metabolic syndrome, so a bypass compared to a sleeve may be better. But then there are other authors who will claim that sleeve gastrectomy will not disturb the absorption of nutrients, and the baby, the fetus might have a better growth. So arguments on both sides. I just wanted to put the the stuff from the evidence and from the systematic review point of view. Published in 2019, the bypass was shown to be better. Now, type 2 diabetes, if you have a patient with obesity, a quarter of them will be diabetic. Now that means, and in our Asian cohort, metabolic syndrome occurs at a much lower BMI. So even at a BMI of 30, you will see a lot of diabetes. So at a BMI of 40 and 35, a lot more compared to a Western people. So it is known that the surgical weight loss is better. The Stampede trial established that the surgical therapy plus lifestyle management was better than medical therapy and lifestyle management. It was evident at the end of 5 years of randomized controlled trial by the Cleveland group. What they also showed, as well as a systematic review which included that trial in 2020, that the gastric bypass was better than the sleeve gastrectomy in terms of management of diabetes in a long term. Now, I will exercise caution here. There will be patients whose diabetes have burnt out. They have become from type 2, the C-peptide levels have fallen, the pancreatic beta cell function has fallen. In those patients which are potentially entering into type 1, will a bypass be better than a sleeve? Well, we don't know. It is also known that in terms of two bypasses, the one anastomosis or the mini gastric bypass versus Roux-en-Y, at least one review of literature suggested that in terms of anti-diabetic effects, a mini gastric bypass was doing better. And also we believe with the same data based on our experience. GERD or hiatus hernia. Now this is a huge Pandora box that I'm opening for you. With a sleeve gastrectomy, there is an increase of GERD of 19% based on a meta-analysis, 2020. The de novo GERD, so a quarter of the patient who did not have GERD to begin with start having heartburn and reflux, and 20% of those who had it worsened. And if you look at them endoscopically, a quarter of them were having esophagitis, and 1/10 of them had a Barrett's in a long term. And therefore, 4% of the sleeve were revised to Roux-en-Y at that point of time. Maybe with more time, more patients will be revised for GERD. So it seems that sleeve gastrectomy is not the right procedure for an obese patient who already has a heartburn and reflux symptomatic. Also, whether if they have endoscopic esophagitis, would you not do a sleeve? Another question altogether. But from symptomatic point of view, if you listen to your patient saying, I've got heartburn and reflux, my BMI is 40, you think of a procedure, don't think of sleeve, right? But that's from my point of view, from evidence. But you may do otherwise also, as I'll show you. So Roux-en-Y gastric bypass is better because the best anti-reflux procedure. However, I like following this in my practice by Kavanagh. So if you have a patient, a lot of patients come asking for only sleeve. They don't want to do a bypass. And they still have a GERD, like 1/5 of the patients have GERD with our bariatric cohort. So if you have GERD, you do an endoscopy, and if you find that the patient desires RYGB, fine, that fixes it, that's RYGB. But the patient does not desire RYGB, wants a sleeve still, despite the fact they have reflux and they have a endoscopic esophagitis. Do a pH testing, do a manometry then. And if you find that they are normal, then it means this is a symptomatic reflux, could be functional, or there are so many other terms I don't want to use because I'm not a gastroenterologist, but it is permissible to use a sleeve gastrectomy. Whereas if they are abnormal, then it is not permissible even if the patient wants. Right? So that is something that I do it in my practice. Finally, time's up, so great. Cirrhotic patients or NASH patients, or just say CLD patients, because the spectrum is NAFLD, NASH, cirrhosis. With NAFLD and NASH, I will tell you what the data says. So in gastroenterology 2020, the medical gastroenterologists with the surgeons decided, okay, fine, in France they did this patients of 125 patients where the biopsy was done, liver biopsy before and after the surgery. And they looked for 5 years these patients. Resolution of NASH was 84%. That's a strong data. Very strong data. And there was reduction of fibrosis which disappeared in 56%. Half of the patients had a reduction in fibrosis, disappearance of fibrosis. I think that's excellent data to suggest. And recently, Ali Aminian with a RCT convincingly proved that the bariatric surgery is better than any medical therapy for patients with NASH and NAFLD. And in these patients, sleeve gastrectomy was preferred over bypass, published in a journal in nutrition. So if you look at bariatric surgery journals, you might get otherwise, but they realize that if the nutrients are taken away, as in a bypass, less absorption of good nutrients, then it's a possibility the liver function will deteriorate. So sleeve gastrectomy. I will stop here because my time is up. Okay, thank you. So what about concomitant hernias? Now that's a huge area of research. I think it's a huge area, and we have published at least one paper on this. So if you have an obese patient with an umbilical hernia, and the patient came to you for hernia, but the patient's weight is 130 kilos, would you address that hernia? Probably not. Probably not. And if you had to do a bariatric surgery and then do a hernia, patient might not agree. Then what? And finally, if you had to do a bariatric surgery and the patient agreed, what procedure will you do? And if that omentum is all there inside and you want to do a stage procedure, will you take down the omentum? So those are the questions. Let me try to answer a few of them. So first of all, it is now known that if you treat the obesity first and then the hernia, the recurrence, the SSO, the SSI, and the cost and the complications are all reduced. This not only came from this paper, but also a paper by Shandiz, and there's an AHS, ASMBS guideline after looking at the literature that if you do a staged repair, it's better. But then staged repair, would you do it for, let's say, a BMI of 37 with a small umbilical hernia? No. In that case, it is said it is feasible to tackle this patient with a laparoscopic procedure like an IPOM plus with a bigger overlap of mesh with more fixation. So smaller defects in a favorable obese, you can do a medical weight loss and do an IPOM plus with a bigger mesh overlap and more attacks, more fixation. Whereas if you have a larger hernia, a larger patient, it is better to go for a staged repair. Those are the guidelines. And this is the guidelines I was talking about. So it is, I think it did not compress. Okay. And what bariatric procedure would you use now? So if you see a patient whose hernia you have to tackle and there is an omental plug in the, in the gap, it is preferable that you apply the bariatric procedure which is optimal for the patient. For example, as I mentioned today, if the patient has got a patient has got diabetes, you would like to do a Roux-en-Y gastric bypass. Then go ahead and do a Roux-en-Y gastric bypass. Do not disturb the omentum which is there in the hernia. If you can do without it, do it. Let's say you had a hostile abdomen, or you had a patient who who will merit with a sleeve gastrectomy, in your opinion, young patient. Go ahead and do a sleeve gastrectomy. So don't deviate from the process of choosing the optimal procedure based on the hernia. Just leave the hernia there, and if technically it is possible, do the optimal procedure. And 6 months down the line, 1 year down the line, and some papers are talking about 20 months median, 20 months after the surgery, you can go back in again, assess the hernia now. Does the hernia deserve an IPOM plus? Does the hernia deserve an open abdominal wall reconstruction? For example, a large hernia might warrant let's say an open reef stopper with an abdominoplasty. There's a lot of sagging skin, especially after your bariatric surgery. Then in one go, you could do the paniculectomy. You can do an open reef stopper repair for that patient and give a good cosmetic result to the patient. So with a staged repair, remember you have the option of exercising a good choice for your bariatric procedure and a good choice for your hernia procedure. Whereas if you do concomitant surgeries, which means that you're doing, I saw a BMI 37 with a hernia, I want to do an IPOM and I want to do a sleeve because that's the simplest thing. Maybe the sleeve wasn't perfect for that patient. Maybe the IPOM wasn't perfect for that patient's hernia with defect. So you chose a suboptimal bariatric and a suboptimal hernia procedure. So those are the thoughts based on the guidelines. I mentioned this. Those who do concurrent hernia bariatric surgery in IPOM plus, remember that this paper by Rollo Rosenthal's group showed clearly that 15% of the Roux-en-Y gastric bypass patients at the end of the procedure had positive bacterial culture. So even if you got away in the short term, there's a possibility that the long-term SSI rates will still be high with a Roux-en-Y. So if you're doing concurrent repairs for these patients, those who agree for bariatric and hernia repair, a Roux-en-Y gastric bypass probably is inferior, although surgeons have shown that they can do it, but it is inferior to the sleeve gastrectomy. So for the take-home points, I just made one slide which we do in our practice. Young patients, okay, elderly I did not put because that may be a little controversial. Prohibitive adhesions, sleeve. Young patients, sleeve. Smokers, sleeve. Concomitant hernias, I will prefer sleeve, but I will do an optimal procedure if it warrants. Cirrhosis, sleeve. If I had to do, referred by the liver transplant team, we'll do a sleeve. Future pregnancy, although the evidence favors gastric bypass, we do sleeve. For a Roux-en-Y, a GERD patient directly goes for Roux-en-Y unless the patient doesn't want it, as I showed you my algorithm that we can change based on further tests. And for a mini gastric bypass or a one anastomosis, super obese goes for one anastomosis, diabetic patient, a florid metabolic syndrome patient goes for a one anastomosis gastric bypass. So with that, I thank you very much for giving me this extra time as well. Thank you.
Thank you, Dr. Sarfaraz. It was an excellent presentation. If you, anybody from the audience would like to ask him questions.
Let me ask, would you tailor your surgery whether the patient is vegetarian or non-vegetarian?
So we studied one anastomosis gastric bypass, which is more malabsorptive procedures than the others, and we saw that the vegetarian cohort had a lower transferrin level than the non-vegetarians. And therefore, although I think a counter argument to this has been made in the book that I contributed to in the Essentials of Anastomosis Gastric Bypass in Vegetarians. So when I looked at the literature, it doesn't show any difference. But it may be different from geographical locations. For example, in our city, we get to see a lot of patients who are hardcore vegetarians. Even the non-vegetarians do not consume so much of protein. And finally, another angle to think of is, even if we say 60 grams of protein for the first 6 months, which is the decisive factor for protein deficiency, most patients land up having 30 or 40 or 45 grams of protein. Whether they are vegetarians or non-vegetarians doesn't matter, because the whey contributes similarly to the eggs and the meat. So somewhere I think there are too many variables that we are not able to factor in, and that is why some literature do not show any difference, whereas some literature like our own audit and our own data showed that there is a difference in the transferrin level. So I think I am very cautious in exercising one anastomosis gastric bypass, which is the malabsorptive procedure, in a vegetarian. I do not hesitate to use a sleeve and a Roux-en-Y gastric bypass in a vegetarian. But if it's a vegetarian, I take a little bit of a caution in doing one anastomosis, and if I'm doing it, I'll not exceed the limb beyond 150 centimeters in these patients. I've had 2 vegetarians in my 12 years of practice with one anastomosis gastric bypass who landed in the PEM and then came out medically. But 2 vegetarians landed in a PEM. I have no non-vegetarian who landed in PEM.
Small question. In the super obese category, your results would be better with a, you said they are better with a one anastomosis as compared to the RYGP. As was shown in your results in your study too,
yes,
probably.
It did.
So that is something that is,
Yeah. I can confuse that issue a little bit more, but I think today it's not the right time. It depends on the definition you apply for weight regain. If you apply weight regain as 5 BMI points and 10 kgs, the results will be different when we talk in proportions.
Correct.
In terms of proportions, the weight regain percentage in super obese is less. That's confusing. Weight regain in terms of, this is across all bariatric procedures. If you just look at the weight regain in terms of, okay, somebody gained back 10 kgs, then if you apply that definition, all super obese have got weight regain.
Exactly.
But if you apply 25% and you compare that patient with somebody with BMI 35 to 40, you will find that the BMI 35 to 40 has more weight regain than the super obese. That's confusing, but I will have that discussion maybe over tea and coffee.
Another small point, in the liver, there was the NFALD and NASH with fibrosis, with proven fibrosis. Do they have, reversal of the fibrosis in the term of KPAs on basically whenever you do a OAGP or a...
Yeah. So this French study was with 124 patients who had liver biopsy prior and after. And with those patients followed for 5 years, 56% showed disappearance of fibrosis. So I think that's very hard hitting evidence suggesting that the fibrosis is reversing. I think the physicians could go back to the books and stop writing chronic progressive condition for cirrhosis. Not cirrhosis, maybe fibrosis, because this was basically looking at the histological picture and then seeing the reversal. So I think that portion is very encouraging. And the same thing was seen by Ali Aminian, recently published, RCT, where he looked at medical management, just like Stampede looked at medical for diabetes. Here they looked at medical management versus surgical management for established CLDs, and they found at the end of, I think, 5 or 8 years that there was a reversal of fibrosis. There was a resolution of NASH.
Yeah, Sarfaraz, again on the CLD, you said you will prefer only sleeve, but in my experience, I do bypass, and that to Roux-en-Y with long pouch.
Yeah.
See, they deteriorate, cirrhotics will deteriorate only when they develop ketosis, the starvation ketosis, which is common even after sleeve gastrectomy. So there are high chances of reversal. The encephalopathy in post-operative period.
Yeah.
So I personally modify it. I don't take long limb, like don't take even 150, maybe 125 or 100 centimeter of BP limb and 100 centimeter of root limb and larger pouch, so that they can eat well. We feed them early, maybe after 2 hours of surgery, even glucose containing food they can take after the surgery, and they don't go into complications of.
Right. Yeah, so that is a topic, I shared the evidence published in the journal called Nutrients in 2021, which is recent, which looked at all the evidence, and after looking at all the evidence, they said that if the nutrients are not absorbed, one is ketosis, that's a different thing, dehydration, starvation, that deteriorating liver function is one area, and the other area is the nutrients not getting absorbed and producing chronic, more medium-term liver dysfunction. And that is what they looked at all the literature, and they decided. I have seen that in bariatric surgery journals like obesity surgery, these did not figure in. And as a reviewer for that journal, I can tell you, most of these negative downsides are shot down very immediate in these journals. So you have to look at the allied health professional journals to see a neutral point of view. I'm not saying that this is right or wrong. I'm saying that there's just an evidence which exists there, which is strong. And if you go back 20 years, then the duodenal switch was taken off from the European country because of the risk of liver failure. They just stopped the program of using duodenal switch completely because the incidence of liver dysfunction was very high.
In fact, these patients who are having CLD, they have diabetes is a concomitant disease. So because diabetes also contributing to the fatty liver component.
Yeah.
So if we do a bypass, I think we can have more long-term remission of diabetes, which will contribute further in the reversal of fibrosis.
So to carry that discussion a little further, most liver dysfunctions happened in the first year, and then there is another cohort which presents 3 to 5 years later with cirrhosis. The European study was about late cirrhosis, and there are so many papers which basically talk about acute liver dysfunction. So acute liver dysfunction would be one area, because that's what you're saying, that the diabetes resolution all happens in the dichotomy starts a little later between sleeve and bypass. At 1 year it's the same, at 2 to 3 years it starts diverging, and then you see more benefits with the bypass on diabetes compared to sleeve. So similarly, I think the malabsorptive procedures versus the restrictive procedures, they show some dichotomy on liver dysfunction later on. Benefit or side effect will depend on what we see, what physiology is working more at that time.
Thank you.
Yes, please. So that's an excellent question. As you know, there is a procedure called Nissen sleeve, which is becoming popular in some parts of Europe. At the moment in our country, I do not think surgeons have adequate exposure or experience with this procedure, but this is primarily a European concept of using the sleeve in patients who have GERD and then adding something to it during the procedure which can reduce the GERD in the short term and in the long term. Let me give you some of my thoughts on this, because I've done extensive study on that literature. Earlier surgeons used cruroplasty. They looked at hiatus hernia and they said, okay, this is going to contribute to GERD. So they dissected the stomach back, did the cruroplasty, and then they did the sleeve, even in patients with GERD, obesity with GERD. And some found good results, some did not find good results. If you look at the literature, it's like equivocal, both sides. So when you see equivocal results, try to think that this is probably not working. It's better to be skeptic as a reviewer than to be, a proponent. Second, this came in about the Nissen. This is not a new concept. It has been there for quite some time. It's just getting popular now because surgeons have woken up to the idea that a tenth of the patient is having Barrett's, a quarter of the patients are having, de novo reflux. So that has woken them up to do something about it. So Nissen is the anti-reflux procedure and the sleeve becomes the bariatric. We have to see the durability of the response. We have to see the short-term efficacy. So there's not enough data, no durability as of the moment. It may work, it may not work, but going by cruroplasty plus sleeve, equivocal results, here we do not know. We will probably see, but if that did not work, I'm not sure how much this is going to work in the long term. The algorithm I showed you, where if you see GERD in a patient and if you can do the pH study, the manometry, and establish that those are normal, the pressures are okay, the pressures are okay, the pH is okay, and this subjective heartburn and reflux is probably more functional in nature, probably those patients are going to benefit only with the sleeve. So I think it's just a little hazy, I know, but if you start jotting down the algorithm and start jotting down all the literature is available and see what is clear and then forget the hazy, what will remain is this, that if you see a patient of sleeve with GERD and the patient doesn't want to bypass, then a sleeve you can apply with the idea if the other pH study and manometry is okay. And if you wanted to add something, then you could do a cruroplasty or a Nissen sleeve with query outcomes.
I think it all depends on the size of hiatus. So a person coming to you for hiatus and who is obese, I think we need to add a fundoplication by using a remnant stomach. We can always do a fundoplication and do a Roux-en-Y gastric bypass or MGB, whatever you want to do.
Also, anybody who is coming to you, suppose somebody does a sleeve. A lot of sleeves come who have lost their weight, excess weight, and they're doing well otherwise, but now they're having severe reflux. Now, anything short of a RYGB, what can be done?
So when we see reflux, it has to be categorized objectively with a GERD questionnaire. That's the scoring that you have to apply. A2 endoscopy will be a part and parcel. Whenever we say GERD, in my practice, I had a 4-GERD clinic, by the way, in the city. So 4-GERD clinic, if I told you that 70% of my patients with GERD are functional, would you believe it? 70% of our GERDs, heartburns and reflux, you evaluate them and the team ultimately lands up with a diagnosis of a 70% functional GERD, which means you got nothing on the table. So that's where I want to begin from. Even with post-bariatric procedures, you see these patients, many of them would be just a functional heartburn and reflux. If you can follow this up with endoscopy to show esophagitis, again, interpretation, LA grade A means nothing, B and C, okay, you wake up to the call. If you see Barrett's, okay, you do an RFA, but if it is asymptomatic, why bother? You want to now go beyond this, beyond the PPI and counselors and and your lifestyle management, and you want to do something more for this patient because this patient is still complaining. Then you do a pH study, a manometry, to evaluate them further. And if you can convince yourself, not the patient, if you can convince yourself that there is a hiatus hernia, which many patients have either ways, doesn't mean anything, right? There's a terminology called ITSM, intrathoracic sleeve migration, which will happen for all tubular sleeves. Almost all tubular sleeves will have a little bit of ITSM because of crural depletion. The hiatus increases, the sleeve goes inside. That's nothing. But then if you have an established large hiatus hernia, you have grade C esophagitis, your pH study shows that the scores are very high and the manometry is normal, then that is the patient we can take up for a Roux-en-Y gastric bypass. It is definitely not a good idea to jump the gun, and as I said, in just normal population, 70% in my practice, in my foregut clinic are functional. So, lot of caution to be exercised here.
One more question. You asked about this question about the GERD. Are you a bariatric surgeon? Huh?
He started doing that.
Yes. And this is where I was coming to. There are three major procedures we are discussing. One is a sleeve, one is a RYGB, and one is a MGB.
Yes, sir.
Those people who are starting to do the sleeve, bariatric procedures, they do not do RYGB. They either do a sleeve or they go for the MGB because they are easier procedures than the RYGB. So, what he was asking, so somebody who is starting to do the bariatric surgery and he gets a patient of obesity with established GERD, what he is going to do?
Yeah. So, if you can bring this slide back, that is the answer to that question. Can you bring that slide back? So, this is what I was saying. A lot of surgeons would want to make their practice centering around sleeve because of technical ease, less post-operative complications, and definitely less cost in the long term also. And the patients also are there who are only sleeve minded. Many of patients will say, no, I don't want any bypass, sleeve. So surgeon desiring sleeve, patient desiring sleeve. Now, that's the cohort we are talking about now. In that cohort, if the patient has GERD and you are sleeve centric, then this is what you can follow. Patient desires LSG. You did patient had a GERD and obesity. So you thought, okay, I still want to do sleeve. You did an endoscopy, grade A esophagitis. You don't pay attention to that, it's okay. Desires sleeve, yes. pH testing and manometry. And that is normal. You go ahead and do sleeve. It has not been shown that this cohort of patient is going to have any different outcome from the patient who has, otherwise. So this patient will still do well. It's only the other one, the esophagitis patient grade C, a hiatus hernia, those patients, if you just do a sleeve, a quarter of them are going to have more heartburn and reflux, a tenth of them are going to have Barrett's, and the symptoms are going to increase, the de novos are going to come up. So those are the patients that you will have to, be ready for that complication to come up if you're not doing a Roux-en-Y gastric bypass. So there is going to be a cohort of patient where if you still apply sleeve, it will be a problem. Now you could think further that okay, then I'll do a sleeve plus cruroplasty, or I will do a sleeve plus Nissen, and that is going to take care of my long term. But then that is poor evidence, weak data. But you could be on that boat and still sail and look at these patients, how well they do, because none of us know the answer in this room. Whether those patients are going to do as well as the RYGB for the reflux. Is it going to be acceptable complications? So we do not know. Yes, Siddharth.
Can we replace an RYGB with an OAGB?
RYGB with?
It's an OAGB.
OAGB? Okay, so again, complex. OAGB surgeons, there's nothing called OAGB surgeons, sorry. So bariatric surgeons who perform OAGB, many of them have shown that the reflux rate is about 2% to 5%. That's what they have published. And in our cohort, we see about 8 to 10%, I think approximately. If earlier, if you had asked me 10 years back, based on the data that was available, because the reflux rate reporting was so low, I thought the OAGB, because of the fact that it is a low pressure system, and because they say that the bile comes from the afferent limb, goes into the efferent limb, and doesn't ascend up into the esophagus or the proximal stomach, because there is an intact LES, I don't think so anymore. With our own experience of more than 500 OAGB patients and following them up assiduously, I don't think so that anymore. There are patients who begin with a no GERD symptom, no reflux, but with an OAGB, they do complain of bile coming up in their chest. So there is a cohort of patients that it's happening to. So now preoperatively, I also do a routine endoscopy. And if we find that these patients have evidence, there was a symptomatic reflux and they had a esophagitis or a lax LES, these patients are not going for OAGB in my practice. If you look at evidence, still at a very nascent state. So from 2 to 5%, only very few authors have shown a higher bile reflux rate in their own cohort. But once they have it, they have shown that they have done a revision into a Roux-en-Y and the bile reflux has gone. So I just gave you what evidence says and what I would, how I would think.
I think the time is up. Thank you, everybody. Thank you, the speakers, and thank you, chairpersons.
Thank you very much. Thank you, audience. I think we were very few, but I guess whenever we talk about niche things like bariatric surgery, you're not going to get quantity, but only quality audience like yourselves. Thank you.